Our situation for chest pain is a 45-year-old male presented in the ER with dyspnea and clenching his chest. Upon admission, the patient states he was shoveling snow and began to feel uncomfortable chest pain that occurred before, which was relieved with rest. However, his symptoms were not resolved by rest this time. Alarmed by his pain, he decided to seek emergency medical help.
Have you ever been in a situation such as this in which you were unsure what to do?
Well, not a problem. Following these simple guidelines and watching our video, healthcare providers like yourself are able to follow our steps and to safely and act promptly.
However, this is simply a training module, so please always refer to your hospital policy and procedures and always don the appropriate personal protective equipment as necessary.
So we're going to start off with our primary survey. A primary survey is very important. It includes airway, breathing, circulation, neurological, and environment. And with our primary survey, it should take up at least 1 to 2 minutes and 1 to 2 minutes upon the patient's arrival. And in doing so, this should never ever be interrupted unless the patient is having a cardiac arrest or if you're administering something for airway obstruction. So for primary survey, we're going to start off with airway. We're going to put on our gloves and make sure you assess the patient, make sure you have the right patient, assess the patient's level of consciousness. Can you please tell me your name, please? Can you please tell me where you are? And can you please tell me the time? And in doing so, if the patient's able to speak to you, then you have an idea of whether the airway is obstructed or not. You want to see if the patient's in respiratory distress. And then you want to see if there's any foreign object in the mouth. If it is, you want to remove it with the Yonker. Then you want to assess if the tongue is blocking the pharynx, if there's actually blocking the airway as well. Then you want to make sure you do a jaw thrust, making sure that the backboard is flat, and making sure that the cervical spine is in neutral position using like a backboard or even like a soft roll. And then also, if the patient is unconscious, you want to make sure that you give them an oropharyngeal airway or give them a nasopharyngeal airway.
Moving on to breathing, we're going to assess ventilation, ensure that the patient is breathing effectively. We're going to look for paradoxical movement of the chest wall during inspiration as well as expiration. We're going to look, listen, and feel, and we're going to auscultate the lung sounds. Upon auscultation, if the left ventricle is affected, you will auscultate adventitious lung sounds, which indicate that there's pulmonary congestion. We're also going to assess for any use of accessory muscle use, nasal flaring, as well as any tracheal deviation, as well as assess the jugular vein. And if it is distended, it indicates that there is systemic congestion. Also, we're going to assess the patient's respiratory rate. It will be elevated above normal. And this is because the heart has decreased oxygen and has an increased oxygen demand, so the body is compensating by increasing its respiratory rate. So interventions that we will do for this patient is we are going to administer 1 to 2 liters of oxygen via nasal cannula. We're also going to sit the patient up in high Fowlers. And if we auscultate no lung sounds, no breath sounds, we're going to prepare for a chest thoracotomy.
All right, so we're going to move on to C, which is circulation. So you want to assess the patient's overall appearance, assess their face, their lips for any signs of cyanosis. You want to check the 3 pulses, so radial, femoral, and carotid. You want to check the quality, so if it's bounding, if it's weak, if it's thready. You want to check if it's irregular, if it's regular. And then we're going to move on to assessing the skin color and temperature. So if it's cool, if it's warm. We're going to be checking the cap refill. So ideally you want it less than 2 seconds. If it is greater than 2 seconds, that means there's decreased perfusion to the peripheries. You're going to be assessing the jugular vein to see if there's any distension or not. And you're going to do your CMS, so color, movement, and sensation. You are going to be assessing the patient for any diaphoresis, cool, clammy skin, any tachycardia, because this can indicate hypovolemic shock. So moving on to interventions, we're going to initiate CPR, ALS. If the patient's pulseless or breathless, you're going to be, if the patient was presenting shock symptoms, you're going to be inserting 2 large bore IVs and administer normal saline or Ringer's lactate or blood products if ordered. You're going to be obtaining a blood sample for electrolytes, random BG, type and cross match, and so on. And that's it for circulation.
Neurological. as we're assessing neurological, we're gonna assess the patient's level of consciousness. Ask, hey, can you please state your name for me? Can you please tell me where you are, and can you please tell me the time? And in doing so, you want to assess the patient's Glasgow Coma scale. You want to assess if the eyes are moving spontaneously. If you want to assess any motor response, and ask the patient if you can grab onto my hands, and if they feel any resistance, the patient's actually obeying into my commands, and if they're actually responding to me appropriately, so a verbal response. So are they oriented to place in person and time, and assessing if patient's actually in any confusion. Then you want to assess patient's perla. By doing so, you want to assess the patient's pupils, if they're equal and reactive to light, and if they're accommodating, and there will be some possible decreased level of consciousness because there's decreased perfusion to the brain.
Moving on to exposure, we're going to expose the patient to examine them appropriately, as well as while we do this, we're going to maintain their dignity.
All right, so now we're going to be moving on to the secondary survey, which includes F, G, H, and I. So F stands for full set of vitals. So usually with someone with MI, their beat and heart rate is increased, and this is due to the response to release of epinephrine and norepinephrine. So usually the BP is high, but then it decreases due to the decreased cardiac output. The respirations are increased due to the body's compensation for decreased O2. Temperature may be elevated to 38 degrees within the first 24 hours, and this is due to the systematic manifestation of the inflammatory process by the myocardial cell death. And O2 is obviously decreased because the myocardium is deprived of oxygen. And you want to also facilitate family members in this situation to inform them what's going on.
Awesome. And then we're going to end it off with giving comfort. The patient's going to be feeling really, really anxious, so you want to reassure them and kind of decrease the anxiety. And then you want to do a history sample. And in doing so, you want to make sure you assess the patient's symptoms. So you want to ask a general question of how are you feeling? Because women and men experience chest pains a bit differently. So if a patient may have, a woman may feel epigastric pain, or may feel like nauseous or having a headache, while a male will have radiating from the jaw to the arms to the hands. We want to make sure we want to assess any allergies that the patient has. So ask them, what allergies do you have? You want to assess the meds that the patient's on. So it may possibly be on nitro, rovastatin, Pantoloc, a possible Ramapil. Then you want to ask the patient for their past medical history. Say if they're hypertensive, that's why they're on Ramapil, and if they have a Pantoloc, that's why they possibly have GERD, or just to see possibly if the patient has dyslipidemia, that they're going to be on rovastatin. Then we want to assess the patient, ask them, what was your last meal? Maybe the last meal interfered with the event, or we want to make sure that we want to keep the patient NPO so we can get ready for surgery. Then we want to assess the patient, ask the patient what event led to the situation. Then once you finish that, you want to make sure you do like a complete full head to toe. For example, you can look at the patient's face by looking at the symmetry of the eyes, face, nose, and mouth. You want to assess the patient's level of consciousness, Glasgow Coma scale. You want to assess the patient's extremities, if they can actually do their circulation, movement, and sensation. Maybe assess their bowel sounds, vital signs, like a complete full head to toe.
Moving on from there, we're going to do a complete pain assessment. We're going to assess what provoked your pain. What were you doing when the pain happened? Then we're going to assess the quality. Is it sharp? Is it stabbing? Is it dull, or is it crushing? This will give a good indication of what type of situation you are dealing with. Then you're going to ask the patient, does your pain radiate anywhere? Why we ask this is because men and women experience different types of symptoms when they are experiencing NMI. So whereas women might experience epigastric pain, nausea, or a headache, men will experience radiating pain to the left shoulder. So after that, we're going to ask them the severity. On a scale of 1 to 10, how bad is your pain? Also, after that, we're going to ask them about the timing. When did it start? Is your pain continuous, or is your pain intermittent? We're also going to ask them, is your pain relieved with rest, or is it not relieved with rest, which will give us a good indication if they are stable or unstable angina. Also, which will help us with our diagnosis. Also, we're going to assess the Understanding. Do you understand what's happening to you? Also, we're going to ask, has this happened to you in the past?
All right, so moving on to the final component of the secondary survey, which is eye. So we're going to be inspecting the posterior surface just for any abnormal findings that were missed during our head-to-toe assessment. All right, so after you've completed your primary and secondary survey, we're going to be moving on to documentation. So you want to document all your findings and all your abnormal assessments, and you want to do an ongoing monitoring, and you want to document minimum every hour on the patient. And you also want to include your documentation and update the TNP, the therapeutic nursing plan, and just update it as you go throughout your shift. And assess the patient if they had any past vaccinations. And that's pretty much it for the primary and secondary.
Awesome. Then we're going to start off with our interventions just to save the patient. So where do we start?
I'm going to initiate continuous ECG monitoring to determine the underlying cardiac rhythm. Also, I'm going to obtain a baseline blood sample to see if there's any cardiac markers such as troponin and CKMB, which indicate cardiomyocyte cell death.
Then I'm gonna obtain a chest X-ray just so we can rule out pulmonary embolism or pleural effusion. I'm gonna obtain an ECG as well, and I'm gonna administer antidysrhythmic meds if indicated by the doctor.
All right, so I'm going to be administering medications as ordered, such as morphine to dilate the coronary arteries and decrease the patient's anxiety and chest pain. Also, nitrous spray if it's ordered by the MD to dilate the coronary arteries, and we're going to be giving it sublingual, so three sprays every 5 minutes, and within that 5 minutes that you're waiting, you're going to be assessing the blood pressure and heart rate because it is a vasodilator, and if the chest pain does not resolve after the third spray, you're going to contact the MD immediately. And then we're going to be administering antiplatelets such as aspirin or beta blockers for cardiac-related chest pain.
And I hope you enjoyed the video.
Thank you for watching.
Thank you.